So here's my disclosure. So just in terms of numbers, you can see that we're a small community compared to the adult cardiologists, and these are some of the numbers of submissions over the years, and you can see it's actually increasing as well. So definitely we're making our news through the congenital community, both nationally and internationally. Oops. So 2025 so far in the 4 months, we've had 15 submissions. So again, you can extrapolate that to 45. Small numbers by your standards, but it's important to us. Of course, now that we have the images and case reports, there are some congenital submissions as well. These are just some of the numbers for the last few years. We added the hemodynamic pearls, and I know that Guru is one of the section editors for that, and we've had 6 of those cases. Conversations in cardiology, which is a new effort. We've had 3 in 24 and part of 25. And of course, there is also the Pioneers in Interventional Cardiology, and we've had one recently, and that's to be published. Here are some of the countries that have submitted. Now, we're a small community, but we're way more, I think, connected internationally than you guys. And again, just from within those small numbers of admissions, there are 15 countries that submitted from outside of the USA. So we're pretty proud of that. In terms of the congenital conversations in cardiology, this is just one example. This was submitted from the Netherlands, looking at 3D rotational angiography, looking at babies less than 5 kilos and how that can help in the complex congenital heart disease that we do. And it's just some fancy, pretty pictures of some of the lesions that are seen where the 3D rotational angiography overlaid onto the images can help us sort of position stents and know where the lesions are. Pearls in hemodynamics. This is an example of a paper where in older patients, at least in the older adolescents, where the left ventricle might have low compliance and pulmonary insufficiency for whatever congenital heart disease, if you put in a competent valve, you now suddenly increase that volume. That can actually shift your LV pressure volume loop to the right, and of course that can lead to elevated end-diastolic pressures, and then of course you have to think about that and manage that post-cath. And so then again, these are just simple hemodynamics that we've learned for our group of patients. So some of this might apply to the adult world as well. Case reports. This is a case that talked about how we implant a Melody valve, that's a transcatheter pulmonary valve, into the tricuspid position on a post-op transplant patient in a kid. And this is another good example of just showing how we can apply some of the technology into some of our patients. And this is the diagram from that case report showing the Melody valve in the tricuspid position. I know that you guys are starting to do that as well. So there are parallel advancements, and I know we can share ideas and crossbreed of ideas as well. We have some pretty innovative techniques and devices. This was a paper actually ended up with the Conversations in Cardiology as well, where for the failing single ventricle, the failing Fontan, there's some ideas on how to put in a transcatheter device to help pump the blood through the Fontan circuit, and that's some 5 different designs on how to do this. Now this is still experimental, but I can see this slowly progressing to clinical trials and helping some of our single ventricles with Fontan circuitry. And those patients will become adult patients that will come to your world as well. So get used to it. Now, this is a secundum ASD. You guys have seen this for 20 years. This is a secundum ASD. Of course, the typical thing is to balloon the size ASD and put in a device like that. Well, guess what? Nowadays, we can actually close sinus venosus ASDs. Now, you might remember in medical school that the sinus venosus ASD is a surgical lesion, right? Basically, it's a ASD in the superior part of the septum, right by the SVC, and it's often almost associated with the anomalous pulmonary vein. So the surgeons have to baffle the left pulmonary vein into the left atrium and then close that hole. Well, guess what? Some clever person out of the UK and Saudi Arabia actually came up with the idea of that. You took a covered stent and anchored it in the SVC and inflate that covered stent so that it opposes the ASD. You can cover that, but now you have to find a way to make sure that the anomalous veins can drain back to the left atrium. And all kinds of techniques have been evolved to either find a way to cause an indentation in the covered stent to avoid the osteostenosis of the anomalous vein. So some very clever ideas of using a covered stent anchored with a bare metal stent, and you can sort of see this catheter going into the anomalous vein, and then just very fancy techniques to protect the veins as you make this inflation. Of course, you can see that here's an example of the device going up, and see how this left vein, which is originally attached to the SVC, goes behind the SVC, behind the covered stent, and still draining the left atrium, but still you don't see the shunting here. So you can now actually close a sinus venosus ASD now. And again, I can see this becoming a bigger deal because they tend to be older patients and may be in your world as well. So that's just to show that. We have some very fancy atrial switch baffles. Again, most of these are in what we call the mustard ascending baffles, and using electrosurgery to recanalize some of the obstructive baffles. So this is just to show that there is a wire that is denuded so that there's metal there through a microcatheter, through a angled catheter here, and then you attach the electrosurgical knife there, if you will, to create the heat to burn and cut. And so it's just to show that that's in a sort of occluded mustard baffle, and using that system, burn through that baffle, get a snare in there, pull it, and get a venous loop there, and then put a stent in and avoid further surgery. Again, these are some of the things that are sort of developing the congenital world. There he goes. Double-barrel stents with side cell crush technique. Now, all you guys talk about this kind of techniques in the coronary, right? I know that there's a bifurcation club, but guess what? There are lesions like this in the congenital space. Now, this has to do with the complex pulmonary veins as well as pulmonary arteries, where you have the bifurcation just like the coronaries. And so there are techniques here. You can just sort of just highlight this. What you really want to do is sort of develop this bifurcation stenosis that has been treated with these techniques with stents. Again, very similar to the coronary world. Transcatheter pulmonary valves. We know that TAVR is a big thing right now. Well, we have the transcatheter pulmonary valve because there's a lot more right-hearted lesions in congenital heart disease compared to the adults. Again, using 3D rotational angiography to collaborate with the surgeons where they can plicate the outflow tract to narrow it down and then go ahead and do the fit analysis and then put a valve in. And so there's just some fancy diagrams showing how this is done in this particular report. We also collaborate with our structural heart disease guys and actually vascular surgeons, where we're dealing with coarctation of the aorta that's next to the subclavian artery. So I know that you guys deal with aortic dissections, where you can have a dissection next to a subclavian as well. So some of the technology has crossed over to us, where we can actually now look at this coarctation and that's next to the subclavian and come up with endoprothesis to open up the coarct, but also protect the subclavian arteries as well. So there's lots of crossbreeding of ideas between the different special services, and I'm really grateful for you guys for teaching us some of this. Hopefully we can teach you some things as well. Pulmonary artery wedge pressure. This actually was interesting, learning that in the kids, when we do a wedge pressure to look for the LA pressure, that is a reflection of the LVED. If there is pulmonary vein stenosis, obviously that should show a much greater gradient. But we found that if you do a wedge pressure high up in the pulmonary arterial tree, you actually can undermeasure that, and therefore you really have to put that catheter deeper into the small vessels to get past all of the side branch before you can actually measure the true pulmonary vein stenosis pressure gradient. So this is what happens when you have a wedge pressure too far up in the pulmonary arterial tree, and then you can have side branches that can basically cause the difference in it. So again, these are just some of the hemodynamic studies that we've learned through this year's journals. We have registries. Just two of them are simple impact registries, the national registry, and the C3PO registry is a smaller registry, but there's been lots of papers out there that will help us. Again, we're a small community. We don't have huge volume like you guys, so we depend on registries to come up with data. So, of course, we have challenges that you guys don't see. For example, we have to think about somatic growth. So when we put a stent into a baby, we have to think about how are we going to deal with that stent when the baby becomes an adult, right? So these are things that we have to come up with ideas on how to fix that. We have to work through smaller vessels and smaller hearts and smaller circuitry. The timing for surgery in the small babies can be pretty difficult, so we have to come up with ways to intervene to buy time for the baby to grow before they have reparative surgery. We think about neurodevelopment. We think about cumulative radiation dosing. So here's some of the papers I talk about. There's a patient who had cannula for surgery, ended up with severe SV stenosis that we have to deal with. We put a stent in this. That stent has to get to adult size, so we have to figure out ways to do that. Just an example of a kid who needed some time to grow before the surgeons can fix him, and we had to put a stent in the ductus to buy that time. Again, this is collaborating with the surgeons to come up with hybrid procedures and how do we buy time for the child to grow before surgery. There's another paper on neurodevelopment. I won't go through some of this, but basically showing that a PDA stent actually has better outcomes neurodevelopmentally compared to a BT shunt, for example. Radiation dosing. Somebody wrote a paper on how to set up the system to give you alerts when you reach a certain radiation for a specific dose for a specific patient. So let me just summarize that the field of pediatric congenital interventions have exploded with new devices and techniques that has expanded rapidly across the globe. We're a small community, but we are integrated pretty well internationally, and it's very collaborative. We collaborate with the adult congenital heart interventions, the structural heart guys, the surgical congenital surgeons, other pediatric subspecialties. We have unique challenges that you guys might not see, but that also leads to innovation. We have our registries, and I think that JSCAI has slowly developed, has been recognized as the journal for the pediatric interventionists, both nationally and internationally. Thank you.